Okay, we will look at adrenal insufficiency today. The other day we looked at the adrenal hyperfunction. Before that, the evaluation of adrenal also we. So adrenal insufficiency we are going to look at. What are the learning objectives of today? What is the adrenal insufficiency? What are the features and clinical findings? What investigations I need? How to make the diagnosis? And then the treatment and follow-up options. And one important entity called the Edisonian crisis that you need to know. So, the hypothalamus, the CRH, the pituitary. Hypothalamus secretes the CRH factor, corticotrophin releasing factor, acts on the pituitary. Pituitary produces ACTH. ACTH acts on the adrenal, and adrenal produces cortisol. Cortisol has got the physiological. This cortisol has got a feedback inhibition on the pituitary as well as on the hypothalamus. So you see, this is very important for us to understand. Zona glomerulosa is the topmost layer of the adrenal cortex, producing the mineralocorticoid aldosterone. Zona fasciculata is the zone which secretes the corticosteroids, cortisone, cortisol, corticosterone. Just below that is the zona reticularis, where the sex hormones, androgens, and estrogens are produced. Below that is the medulla, full of chromaffin cells, and these chromaffin cells produce catecholamines, adrenaline, and noradrenaline. So this is the total schematic architecture. Now, when I come to adrenocortical insufficiency, I have two conditions, just like thyroid, the primary thyroid hypofunction and the secondary thyroid. Primary is from the gland, secondary is from the pituitary or non-gland, outside the gland. Just like primary Cushing's syndrome and secondary Cushing's disease, ACTH dependent, ACTH independent Cushing's we are having. Like that here also, primary adrenal cortical insufficiency and secondary adrenal cortical insufficiency. Adrenal insufficiency arising from suppression of the HPA axis as a consequence of exogenous glucocorticoid treatment is the most common form, occurring in about 0.5 to 2% of population in the developed country. Just like the Cushing, where iatrogenic steroid replacement is the commonest cause of Cushing. Here also the commonest cause of adrenal this one is exogenous steroid administration, which suppresses the HPA, so much of the adrenal. Now you see in this step, adrenocortical insufficiency has got secondary and primary. Secondary is more common than the primary. 90% of the cases fall in the secondary. Secondary means the ACTH is suppressed. Pituitary axis is suppressed. And you measure the ACTH, it will be lower. Primary means the gland is not functioning. As a result, pituitary thinks that it has to send more stimulating hormone. It sends more ACTH and then produces higher ACTH in the blood. Just like primary hypothyroidism, the TSH is very high. In the secondary hypothyroidism, the TSH is very low. Here also, secondary is suppression of the, secondary is due to the withdrawal of suppressive glucocorticoid chemotherapy, glucocorticoid therapy. Somebody is taking, let us say, glucocorticoids for a long while, and that gentleman is suddenly the glucocorticoids are withdrawn. The adrenal axis is suppressed. There is no exogenous steroid. He goes into adrenal. So there is no exogenous source because we have cut off suddenly he stopped. He should not stop the glucocorticoids suddenly. Second thing is, his adrenal itself is suppressed because he is taking long-term steroid. So there is nothing internally is secreted. And that is the common form of secondary hypoadrenalism or adrenocortical insufficiency, wherein if you measure the ACTH, it will be very low here. The other thing is, it could be from the master gland suppression or its master, the hypothalamus. Hypothalamic pituitary disease also can produce secondary ACTH suppression. Okay. What are the primary diseases? As I told you, 10% of the hypoadrenalism is primary from the gland. 90% is from the secondary. Out of the 90%, around 80% is only exogenous glucocorticoid, not pituitary. So what is important? In the history, we must always know whether the patient is on steroids, if so, whether he has suddenly stopped and producing. Okay. Edison, the common things in the primary are Edison's disease, common causes, rarer causes. The one with primary is called Edison's disease, and the secondary one is called the adrenal insufficiency and not called Edison's disease. This gentleman in 1800 and odd, he lived one physician by name Edison, and he described this disease. That's why this is called Edison's disease. He also described pernicious anemia. So the Edisonian anemia or pernicious anemia due to B12 deficiency, intrinsic factor deficiency is also a discovery by Edison. What are the common causes of adrenal gland not functioning correctly? Autoimmune causes, sporadic causes, polyglandular syndromes, PGS. Okay, autoimmune polyglandular syndromes. They are called APS, autoimmune polyglandular syndromes. That means not only this endocrine gland, several other endocrine glands are also affected. In developing countries like us, tuberculosis of the adrenal is also a very common cause. We have, as students, we have seen some cases of adrenal insufficiency due to adrenal tuberculosis. Today, tuberculosis treatment is so good that unlikely to have adrenal tuberculosis. But nonetheless, keep in mind, tuberculosis can be there. Today, HIV and AIDS, metastatic carcinoma, somebody underwent bilateral adrenalectomy as a treatment for Cushing's or for adrenal hyperplasia, he underwent bilateral adrenalectomy, he will have hypofunction. Okay? Autoimmune, sporadic, or PGS, polyglandular syndromes. Tuberculosis, HIV, AIDS, metastatic carcinoma, bilateral adrenalectomy. Rare causes are lymphoma infiltrating the adrenals, intra-abdominal hemorrhage. This is very important. Sudden intra-abdominal apoplexy or hemorrhage, what called Waterhouse-Friderichsen syndrome, following meningococcal septicemia. One of the rare but very life-threatening complications of meningococcemia is Waterhouse-Friderichsen syndrome. So, amyloidosis is a rare cause. Hemochromatosis also is a rare cause. Now, there could be corticosteroid biosynthetic defects. We know 11 beta hydroxylase, 17 hydroxylase, 17 deoxylase, several hormones, enzymes are there. Any defect in any one of those places can produce congenital adrenal hyperplasia also. So, the corticosteroid biosynthesis can be interfered with drugs like meteropone, ketoconazole, etomitidate. These are the various drug-induced suppression of the biosynthesis. So now, what are the common causes? Secondary is the most common. Commonest is a withdrawal of the suppressive glucocorticoid therapy. Hypothalamic or pituitary disease is the next common. Primary is rather rare, around 10% of the cases. The frequency of adrenal insufficiency is roughly around 1 to 2 per 1,000. Okay? 1 to 2 per 1,000. That is the frequency of it. If the Edison's disease is there, that is primary glandular defect, there the ACTH will be higher. Common causes of autoimmune, sporadic, glandular, polyglandular, tuberculosis, HIV, AIDS, metastatic cancer, bilateral adrenalectomy, rare causes like lymphoma, Waterhouse-Friderichsen syndrome, meningococcemia with apoplexy, intra-abdominal hemorrhage, the hemorrhage into the adrenal, and so much adrenal is destroyed. Amyloidosis, hemochromatosis, corticosteroid biosynthetic enzyme defect due to various types of congenital producing CAH. CAH is congenital adrenal hyperplasia. Drugs like meteropone, ketoconazole, and etomitide can also cause. This table is important. Just have a look for 5 minutes. Causes of adrenocortical insufficiency. Secondary is very common. 90% is secondary due to either pituitary disease or withdrawal of the suppressive glucocorticoid therapy. Primary is what is listed there: Addison's, common causes, autoimmune, sporadic, polyglandular syndromes, TB, HIV, metastatic cancer, bilateral adrenalectomy. Rare causes are lymphoma, intra-abdominal acute hemorrhage, or apoplexy due to Waterhouse-Friderichsen syndrome following meningococcal septicemia, amyloidosis, and hemoglobin. And bilateral adrenalectomy due to some disease of the hyperfunction. You remove both the adrenals, then he goes into hypofunction. Just like you remove the thyroidectomy, he goes into thyroid. Okay, corticosteroid biosynthetic enzyme defects. Congenital adrenal hyperplasia, CAH, is the most important of the enzyme defects. Drugs like metilopone, ketoconazole, etomidate are the important. Now, primary adrenocortical deficiency is called the Addison's disease. Anything secondary is not called Addison's disease. Addison's disease is pertaining to the gland itself. The frequency is something around 1 in 100,000. 1 in 100,000. In general, the hypofunction frequency is 1 in 1,000. This is 1 in 100,000. Only 10% of the cases are Addison's disease. Can be fatal, destruction of the adrenal cortex, glucocorticoid, cortisol, or mineralocorticoid deficiency. Now, you understand in the beginning I told you that ACTH influences the cortisol pathway and the sexosteroid pathway. Has got nothing to do with the mineralocorticoid. Okay, if it is primary pituitary or hypothalamus, it affects both the sex part as well as the cortisol, but doesn't affect the mineralocorticoid much in the initial stage. Whereas if it is primarily from the adrenal gland, glomerular is affected, fascicular is affected, reticular is also. That's how you have to differentiate. Okay. Now, primary adrenal insufficiency is the most commonly caused by autoimmune adrenalitis. You have seen primary means autoimmune. Isolated autoimmune adrenalitis can occur, or it can have a part of APS, that is autoimmune polyglandular syndrome. Rarer causes of adrenal insufficiency involve destruction of the gland as a consequence of infection like tuberculosis, infiltration like amyloidosis, hemorrhage like Waterhouse-Friderichsen. Tuberculosis adrenalitis is still a frequent cause of a disease in the developing countries like India. Adrenal metastasis rarely cause adrenal insufficiency. This occurs only with bilateral bulky metastasis. This disease is termed earlier as unforgiving master of non-specificity and disguise. What does it mean? This is a master disease, and this is we cannot we cannot miss it because it could be fatal, unforgiving, and it is a non-specific because the symptoms are so non-specific that unlike Cushing, the patient will come. By appearance itself, I can say, oh, this lady must be having. Adrenal is very subtle, adrenal insufficiency. So it comes in disguise. Now, you are not. Okay. Suspected. When we have to solve, very important thing is unexplained fatigue, hyponatremia, and hypotension. Remember this thing. Somebody comes, listlessness, fatigue, and not able to do anything. From morning onwards, I feel like sleeping on. I am not able to do any work. Maybe hypothyroid, maybe Addison's. Usually Addison's. That amount of fatigue comes in Addison's disease associated with always 90/60, 80/40, 80/20, 80/30. And look at the electrolytes, hyponatremia, hypotension, and hypoactivity. 3 high. Fatigue. Misdiagnosed a viral infection or anorexia nervosa, chronic fatigue syndrome, or depression. Usually they'll say, oh, you had a viral infection. No, that's why you are feeling very weak. They will brush aside and miss that. Or they will say, this could be anorexia nervosa. This woman is depressed also. She is not eating. Probably this is the cause of her weakness and hypotension. Or depressive also look like. So you have to be very careful. Whenever we are dealing with anorexia, listlessness, and then lack of energy, not able, because cortisol is the drive. Cortisol is the energy hormone. If you have cortisol only, I can speak now. If I am speaking now loudly to you in a tone and I am able to sit for a whole day of work because of cortisol. If I don't have cortisol, immediately I feel like going on to the bed. Usually, if you ask them the history, they go, "Sir, I get up at 11 o'clock." They don't feel like getting up from bed, 11 a.m. And then what do you do? I just take a couple of bread slices. I don't have energy to prepare breakfast, eat something and take a cup of milk. And then what do? I sleep again. Then when do you get up? I get up at 6 o'clock. And then what do? I eat some little bit orders, Swiggy, Zomato or something, eat something and sleep again. How the patients? Usually, majority of them are women. Generally, endocrine diseases favor and they love women. It's like men love women. Endocrine diseases also love women. Okay. Secondary adrenal. This is more common. Primary is rare, Addison's, autoimmune, follicular syndrome, adrenalectomy, Waterhouse Flatter syndrome, tuberculosis, story over. Where there, both the mineralocorticoid and the cortisol, both are affected. That's why the hypotension. That is why because of salt is not there, the weakness. Salt is the reason for your strength, isn't it? So that is. Now, what are the secondary causes of adrenal insufficiency? Secondary means not related to the gland, above pituitary tumors, endocrine tumors, inactive tumors, or active. Other mass lesions affecting the hypothalamus pituitary axis. Then infiltrations there due to various substances. Pituitary irradiation as a part of treatment for craniopharyngiomas or some other tumor there in the pituitary they wanted to irradiate. And are we irradiate pituitary for Cushing syndrome itself? When the disease is there in the pituitary adenoma, non-operable location, non-operable, then you irradiate the pituitary. So pituitary irradiation of any nature, autoimmune hypophysitis, just like autoimmune adrenalitis, there is autoimmune hypophysitis. Pituitary apoplexy or hemorrhage, some sort of cerebrovascular accident occurring into the pituitary and causing hemorrhage into the pituitary. Congenital isolated ACTH deficiency, very rare disorder. Drug-induced chronic glucocorticoid excess can suppress the pituitary. Combined pituitary hormone deficiency. That means, all the hormones secreted by the pituitary, like TSH, FSH, CRH, all the factors are depressed. There is only what is called POMC, pro-opiomelanocortin deficiency. Pro-opiomelanocortin is the stimulator for the melanin stimulation. So the pro-opiomelanocortin deficiency also can cause. These are the various causes of secondary adrenal insufficiency. So causes we have generally seen. TB is the most common. This is again about the primary one, adrenal metastasis, lymphomas. Already we have discussed this slide more or less. Adrenal hemorrhage. Okay. Secondary adrenal insufficiency. Commonest cause, usually iatrogenic. You have prescribed some steroid, patient is continuing, and suddenly he withdraws. Then adrenal. Sudden withdrawal of the steroid due to long-term steroid therapy leading to suppression of the pituitary adrenal axis. Symptoms apparent on withdrawal of the steroids. Mineralocorticoid production remains intact. Remember, if it is from exogenous steroid, only the ACTH is suppressed. That means cortisol is only suppressed. Mineralocorticoid has no business to be suppressed by ACTH because it is not under its control. The office is separate. Mineralocorticoid office is from, juxtaglomerular apparatus via renin. It is not through this office. So mineralocorticoid remains intact. Then the important thing is there is no hyperpigmentation. Whereas in case of secondary, in case of primary, Addison's disease, hypopigmentation is one of the important features. Okay? Has decreased there, no hypopigmentation because ACTH is decreased. Other causes are rare and include hypothalamic pituitary axis disease leading to decreased ACTH. So how do I differentiate? Between secondary and primary, secondary is the most common. The commonest offender is long-term steroid therapy, sudden withdrawal. There is no involvement of the mineralocorticoid system. There is no pigmentary disorder. Okay. And hypotension is also to a lesser extent. In mineralocorticoid deficiency, hypotension is pronounced, pigmentation is there, cortisol is not there, and then mineralocorticoid also is not there. So look at the pigmentations. And buccal mucosal pigmentations, gingival pigmentation. You look at the hand, all the creases will be doubly dark. I used to have one patient called Munson. He is a fellow of Addison's disease. And he used to have very dark, we used to call him the African Munson. It looks like an African. So dark is skin pigmentation. The African Munson has come, I used to ask. Because he used to have, these creases are dark. Usually creases are dark for everyone. But then these people have a darker creases than not we all normally have. Another thing is these knuckle areas also are very much, there's metabolic syndrome also. You get the knuckles and then the acanthosis and nigricans will be there. And patella, elbows, flexural folds of the axilla, under the breast, cruri, intracrural regions, the pigmentation. Wherever there is friction, wherever there is joint, there the pigmentation. See the elbow of this fellow, how dark it is compared to his rest of the body. Both the elbows. Like that, gingival pigmentation. And also the pigmentation of the oral mucous is also very common. And they will have, patches of light skin with the dark skin, as you can see here. In the nails also will be pigmented. See the nails there? So it's a very remarkable, unmistakable, particularly in the primary Addison disease and not in the secondary. In secondary, the pigmentary changes are not there. Okay. We look at that. So on the dorsum, you see dark areas are there where normally they should be same color. And you see this is the spatula they have put in the mouth, and you see the buccal pigmentation. They're opening the mouth with the spatula. You may think it is some opening or something. With the wooden spatula they have. And then this one. And nipple areas, hyperpigmentation. Another cause of nipple pigmentation is pregnancy in women. During pregnancy, nipple pigmentation increases, again retreats. Here, irreversible increased nipple pigmentation of male breast as well as female breast also can occur. Okay. Now, adrenocortical insufficiency, we have seen withdrawal of the suppressive glucocorticoid, hypothalamic pituitary. This table we have already seen. Addison's disease, common causes, rare cause. Look at this left-hand side, very important. Whenever there is a febrile illness, the dose of corticosteroid should be doubled. Normal replacement dose is 15 to 25 milligrams, and you need to give double the dose in febrile illness. Minor operation, 100 milligrams IM with pre-medication. Major operation, 100 milligrams of hydrocortisone 4 times daily for 24 hours, then 50 milligrams IM 4 times daily until ready to take tablets. Vomiting, patients must have parenteral hydrocortisone, unable to take it by mouth. And every patient on steroid replacement, they must have a steroid card and they must have a bracelet. Western countries, they give a bracelet. I am on steroids. I am on anticoagulants. I am on anti-epileptics. Anti-epileptic belt will be one color. Steroid belt will be another color. And then this anticoagulant belt will be of a different color. So looking at the belt itself, the clinician, this fellow is an anticoagulant. For that. Okay. So patients should carry the steroid card on. What is the steroid they are taking? How much they are taking? So much the clinician sees fever, 102, it doubles the dose. Like that. If you don't do that, you have not withdrawn, but the steroid you are giving is not sufficient and it precipitates acute adrenal insufficiency. Bracelet and emergency pack. Patient should be encouraged to buy a bracelet and have it engraved with a diagnosis, current treatment, and a reference to the number of a central bariatric. This is ID number of the hospital. Patient should be given a hydrocortisone emergency pack with them, trained in self-administration of hydrocortisone. They should be advised to take on the pack on holiday trips and abroad also. Whenever they go, they must carry. Suddenly, if they feel very weak and hypertension, injection, life-saving. Okay. This we don't follow in our country. We give left and right anticoagulants. We never tell them to have a carb. Anti-epileptics left and right we write, but the fellow will suddenly have convulsions and fall on the ground. No one knows whether he is already an epileptic or not. So this we have to do. We have now how many categories? Withdrawal of the exogenous corticosteroid is one type. Hypopituitarism is the other type. Addison's disease primary is the other type. Congenital adrenal hyperplasia is the last, where enzyme deficiency. Okay, or 21 hydroxylase deficiency. What are the differences between? You see, glucocorticoid deficiency is present in all. It is in the withdrawal, it is in the hypopituitarism, it is in the Addison's disease, it is in CAH also. Weight loss, anorexia, malaise, weakness, nausea, vomiting, diarrhea, constipation, postal hypotension, shock, hypoglycemia, hyponatremia, hypercalcemia. Potassium is high, sodium is low, calcium is high. Patient is hyponatremic, hypercalcemic, and hyperkalemic also, postal hyper. This is about the glucocorticoid, because here all these people are affected. Glucocorticoid deficiency produces all these things. But hyperkalemia is not that severe in glucocorticoid deficiency, because mineralocorticoid is spare. In the generally not affected. But if you see the mineralocorticoid insufficiency, exogenous glucocorticoid does not produce any mineralocorticoid problem. Hypopituitarism, no mineralocorticoid environment. Primary Addison's disease and CAH, mineralocorticoid is also involved. Now what happens now? Hypotension is profound, shock is profound, hyperkalemia is also profound, and depletion of hyperkalemia. There it is dilution. Okay? ACTH excess. ACTH excess means outside somebody, again, withdrawal of exogenous steroid, hypopituitarism, those they are not affected. Addison's disease is there, congenital. So when the excess ACTH is suppressing the adrenal gland, pigmentation, sun-exposed areas, pressure areas, elbows, knees, palmar creases, knuckles, mucous membranes, conjunctiva, and scar tissues. Earlier, I used to have the scars there, but nowadays it's becoming very dark. So scar tissues also, they get hyperpigmented. Adrenal androgen insufficiency, if it is there, then decreased body hair, libido, especially in the female. Okay. So in a woman around 40 to 50 years, if her pubic hair and axillary hair is disappearing, you should suspect adrenal. So absence of or decreased pubic and axillary hair. Signs and symptoms of adrenal insufficiency. Signs and symptoms caused by glucocorticoid deficiency: fatigue, lack of energy, weight loss, anorexia, myalgia, joint pains, fever, anemia, lymphocytosis, eosinophilia. Whereas in Cushing's, eosinopenia. Slightly increased TSH, low blood pressure, postural hypotension. So there are some symptoms attributed to glucocorticoid deficiency. Signs and symptoms caused by mineralocorticoid deficiency: abdominal pain, nausea, vomiting, dizziness, postal hypotension, salt craving, low blood pressure, postal hypotension, and then increased serum creatinine due to volume depletion, hyponatremia, and then hyperkalemia. Signs and symptoms caused by androgen deficiency: lack of energy, dry and itchy skin, loss of libido, loss of axillary and pubic hair. That's what I told. These are the androgen deficiency. Other signs and symptoms: hyperpigmentation, primary adrenal insufficiency only, not in the due to excess of. Hello? Hello, who is this? Hypopigmentation only in the primary cases, not in the secondary cases. Okay. Now, why is the hyperpigmentation? Excess of propioneurocorticotropin derived peptides. So what happens in adrenal insufficiency? The primarily adrenal gland is not secreting steroid hormone. Pituitary thinks that it will influence by giving more ACTH. That excess ACTH acts like a melanotrope and then goes and stimulates the pigment. That is the reason of pigment. ACTH is also melanoreceptor derived peptide like hormone and like melanocortin, and the side effect of excess ACTH is pigmentation. Okay, so all of the things you do. What are symptoms? Already we have a lean person, usually unlike Cushing, who is like this, and then this person is thin and lean, like drumstick. If you blow, he may fall, she may fall. Tanned skin, like African Muniswami, and tired, very tired person, tearful, plus weakness, always crying, because he's very weak, anorexia, he or she, dizzy, faints, flu-like myalgia, arthralgias, depression, psychosis. Another thing is, somebody is having persistent abdominal pain and vomiting, no other cause is found. Think about it. Abdominal pain, all scans normal, liver functions are normal, upper GI endoscopy normal, abdominal pain persists. Vomiting is there. GERD-like symptoms only. But it is not GERD, not liver disease, not pancreatic disease, not biliary disease, not intestinal colic. Must be Addison's disease. Think of Addison's in all cases of unexplained abdominal pain, or this I always remember because we had a patient. We have done all the investigations available in those days to exclude abdominal pain causes. Finally, we looked at the cortisol levels. It's an adrenal insufficiency fellow, supplemented and EB. Abdominal pain vanished. Okay. Pigmented palmar creases in buccal mucosa. When a patient comes, first of all, when I touch him, ask him to look there. Automatically certain diseases are excluded. One of them is Addison. Look at that. Okay. Vitiligo. Unexplained vitiligo, Addison's disease. You can see it in one picture. In that picture, there's vitiligo patches with hyperpigmentation. So postural hypotension also. One cause is Addison's disease. Another important thing you need to know is Addisonian crisis. What is Addisonian crisis? Addison's disease is not fatal. Addisonian crisis can kill the fellow instantaneously because sudden drop in the adrenal function. Hypoglycemia, hypercalcemia, muscle cramps, nausea, vomiting, diarrhea, unexplained fever, shock, coma, high temperature. If a fellow is in shock and he is in coma and the temperature has gone up, one of the important causes is adrenal crisis. What are the tests I do? How do I confirm the diagnosis? Low sodium, high potassium because of mineral. Low glucose because cortisol is the glucose producing hormone. Gluconeogenesis is promoted. Glycogenolysis is also promoted by cortisol. Cortisol is a double way. It is producing glucose into the blood. Supposing we want energy to run from here to there, which is the one which is bringing the sugar into the body. One, of course, is your glucagon. The other is the steroid. Glucagon is instantaneously attacked. But after half an hour, the cortisol also starts sending. Okay, cortisol is very important. Uremia may be there. So you have to look for uremia. High calcium will be there. Eosinophilia and anemia will be there. Okay. Assessment of glucocorticoid. How do I evaluate? There are random plasma cortisol. That means, you take the blood and examine for plasma cortisol level. It is low in patients with adrenal insufficiency. It may be normal range at inappropriately low for a seriously ill patient. Where a patient is seriously ill, running temperature for 1 week, his cortisol levels are normal, means they are low. For that illness, you should have higher cortisol. Or hypermetabolism is there. But the body has not responded. So that inappropriately low cortisol, random measurement of plasma cortisol cannot therefore be used to confirm or refute the diagnosis because it could be normal, but the metabolism may be more and it is less. It is not commensurate with this. So I cannot exclude or confirm unless the value of the cortisol is 500 nanomoles per liter. If it is more than 500, of course, it rules out Addison's disease, which effectively excludes adrenal insufficiency. More useful is the short ACTH stimulation test. So, should I do a random plasma cortisol or should I do a short ACTH stimulation? Preference is to do the ACTH stimulation test. Okay. So, how do I how and when I do ACTH stimulation test? When is required? Diagnosis of primary or adrenal insufficiency. Indications are primary adrenal insufficiency, secondary adrenal insufficiency. Assessment of the HPA axis in patients taking suppressive steroids relies on ACTH dependent adrenal hypertrophy in secondary adrenal insufficiency, so may not detect acute ACTH deficiency, as in case of apoptosis. How the test goes? There is one injection called the synecten. You see ACTH in that. ACTH 10, synecten. Synecten, syn ACTH 10. Syn ACTHN. Synecten is the injection. 25 micrograms of ACTH is used by intramuscular injection given any time of that. You need not give only 80 IM cortisol. You can just, patient walks in, we have a doubt, give 25 micrograms of ACTH injection. Make him take a blood sample at 0 and another blood sample at 30 minutes. 2 samples. Now you know what is the basal level of cortisol. After giving ACTH, what happened you would like to see. 0 minutes also for ACTH on ice in Addison's disease in being considered patient not known to have pituitary disease to be taking or exogenous corticosteroid. So 0, what you have to do, the blood has to be in the ice box and immediately it should be analyzed, because the cortisol that you see in the blood, immediately also you can look for ACTH in the 0 minutes. So before giving the ACTH injection, you have measured plasma cortisol and ACTH, 2 values are there, and then you gave ACTH and measure the cortisol after the 30. Okay, and the sample has to be analyzed immediately. Normal subject, plasma cortisol must be more than 500 nanomoles per liter, either at the baseline or after 30. This is normal. Incremental change in the cortisol is not a criterion. The exact cortisol concentration depends on the cortisol assay being used, whether they're using chemiluminescence or radioimmunoassay. Depending on which assay they are using, the values differ. Now, look at the flowchart. Algorithm for management of patients with adrenal insufficiency. Clinical suspicion of adrenal insufficiency. You're finding it difficult to read. Okay. Clinical suspicion of adrenal insufficiency. What is the clinical suspicion? Weight loss, fatigue, postural hypotension, hyperpigmentation, hyponutrient. If any one or more of these things are there, I have a clinical suspicion of adrenal insufficiency. Then screening or confirmatory diagnosis. Plasma cortisol 30 to 60 minutes after 250 micrograms of posintropin. Posintropin is same as synecten, both are same. IMRIB, cortisol posintropin, that is less than 450, that is suspicious. CBC, serum sodium, potassium, creatinine, urea, and TSH. And of course, sugar also you have to see. They have not mentioned blood sugar. Add hypoglycemia also you want to put it. Then I am in for a differential diagnosis. What are the two things? Is it secondary? Is it primary? Because primary, the treatment is different. Secondary, the treatment is elsewhere. It is in the pituitary. So let's go to the secondary side. Secondary adrenal insufficiency. Low or normal ACTH, normal renin, normal aldosterone. That means ACTH is not coming from the pituitary. Renin is not increased or decreased because mineralocorticoid is intact and normal aldosterone levels. Pituitary has got nothing to do with the mineralocorticoid. Aldosterone is normal, renin is normal, but ACTH only is low here. That means secondary adrenal insufficiency. Then you give glucocorticoid replacement immediately to start improve the symptoms and plan for an MRI of the pituitary, because we are suspecting disease in the pituitary. If pituitary is positive, that is hypothalamic pituitary mass lesion is there, then you accordingly plan and treat. Okay. Here, negative means history of exogenous glucocorticoid treatment. So you must be taking, that is why the ACTH is so low. Exogenous steroids are suppressing the ACTH and sudden withdrawal has caused the symptoms. History of head trauma, consider isolated ACTH deficiency, congenital ACTH deficiency, very rare disorder. Go to the primary side. Most important among the secondary is exogenous glucocorticoids, pituitary. Okay. Primary adrenal insufficiency, ACTH is very high because the gland is not functioning. Reflexly, more ACTH is produced by the pituitary. High renin because the mineralocorticoid deficiency is stimulating renin to produce more mineralocorticoid, and low aldosterone. Unlike there, normal renin, normal aldosterone, low ACTH. High ACTH, high renin, low aldosterone here. Now, both glucocorticoid and mineralocorticoid are deficient. I have to supply both of them. Then adrenal antibodies must be done because I know autoimmune adrenalitis is the commonest form of primary disease. So antibodies are positive, autoimmune adrenalitis, autoimmune polyglandular syndrome (APS). Or it is negative, then take a chest X-ray to rule out any other chest lesion which is causing the suppression. Serum 17 hydroxy progesterone measurement, and in men, plasma very long chain fatty acids also will be diagnostic, and adrenal CT may be done when the antibodies are negative. Suppose I do an adrenal CT. Adrenal CT is positive. Tuberculosis, infection, infiltration, lymphoma, hemorrhage, congenital adrenal hyper. Adrenal is negative. Autoimmune adrenalitis most likely diagnosis. Men consider adrenoleukodystrophy, very rare disease. So, in nutshell, how do you do it? First of all, I have suspicion. How do I suspect? Hypotension, hyponatremia, hyperkalemia, pigmentation, low energy levels. In a female around middle age, this mostly occurs in the middle age. Suspect these symptoms. And hypoglycemia. Screening test, plasma cortisol 30 to 60 minutes after stimulation of the ACTH, 250 micrograms. Normally, I expect to have 500 or more nanomoles per liter as that. Anything less than that is lower. Then I have to do a differential diagnosis, primary versus secondary. In the secondary, ACTH is lower, renin is normal, aldosterone is normal. Glucocorticoid is an MRI, and then they decide whether it is pituitary or not. Whereas primary adrenal insufficiency, high ACTH, high renin, low aldosterone, supplement both gluco and mineral, and adrenal antibodies you have to work out. And then if the antibodies are positive, autoimmune adrenalitis. Negative means it is some other disease related. So the stimulation test. Plasma cortisol before and half an hour after the tetracosaccharide. That is again in the synecta. Okay, 250 micrograms. Or cosindaptin the same. Okay. Edison's excluded if 30 minutes cortisol is more than 500 or 500. Okay. ACTH. So instead of measuring cortisol, you are measuring ACTH, 9 AM ACTH is high, more than 300, inappropriately high, means Edison's disease. And in secondary, it is lower, and you also measure the 21 hydroxy. And adrenal imaging and chest X-ray also. Any past TB, upper zone fibrosis, adrenal calcifications, and then no autoantibody. If no autoantibodies, consider further tests. So these are the various enzyme deficiencies. 21 hydroxylase deficiency, 11 beta hydroxylase, 17 alpha hydroxylase, 3 beta hydroxysteroid dehydrogenase, and finally P450 oxidoreductase deficiency. You can, this is the table from the Harrison. You can see, depending on the variant, which gene is affected, what steroid synthesis it affects, and then what is the diagnostic mark. Okay. Now, assessment of the mineralocorticoid, because I need to assess the mineralocorticoid function also. Cannot be adequately assessed by electrolyte measurement because electrolytes are variable, that for various reasons. Did we do hyponatremia here? We have not done that. So maybe we should do that. It's very important. Hyponatremia must be on the fingertips. It's very difficult, not easy. Hyponatremia. Since hyponatremia occurs in both aldosterone and cortisol deficiency, hyperkalemia measurement finding is common but not universal. Aldosterone deficiency, plasma red and aldosterone should be measured in the supine position and after 5-10 minutes of rest. Because if the patient is erect, the pressure in the glomerular, this one will be higher and the aldosterone levels. So you have to be on 10 minutes on the laying and sir, you have made me lie down on the bed. You are not taking wait. I will come because after 10 minutes only I'm supposed to take. Okay. Mineralocorticoid. Now, how do I treat? Very important thing is replacement. You have to replace. What do you want to replace? Because steroid is not there, you give exogenous steroid. Mineralocorticoid is not there in the primary, you give mineralocorticoid. But 15 to 25 milligrams of hydrocortisone daily in 2 or 3 divided doses. I prefer to give 10 milligrams in the morning and 5 milligrams lunch. So that it covers the whole. Not all at one shot. Give 10 milligrams on awakening, 5 milligrams lunch. 15 milligrams. If it requires 20 milligrams or 25, have an evening dose. Generally, evening dose you avoid because evening dose of steroid makes you mad. Steroid is the active hormone, insomnia problem. So you push if you require more dose, add another 5 milligrams in the morning or another 5 in the lunch. Okay? Generally avoid dosing at night. Fludrocortisone acetate is available. Fludrocort is the tablet form. Fludrocortisone peroral, 50 to 200 micrograms daily. 2 types of supplementation are required for primary. For secondary, only one supplementation, mineralocorticoid, not required because it is not effective. Only cortisone is required. So this mineralocorticoids to correct postural hypotension, low sodium, and high. This is very important. Steroid use. Advise wearing a bracelet declaring steroids. Already told. Add 5 to 10 milligrams hydrocortisone to daily intake of strenuous activity or exercise. Double steroids and then give out syringes such as already. Follow. How frequently I follow this? Every yearly blood pressure, imaging, and add. Okay. All blood tests and imagings, and then the electrolytes are done blood. Watch for autoimmune diseases because the other autoimmune diseases and Edison's disease are together. The same gentleman, Dr. Edison, has described pernicious anemia as well as the Edison's disease. Okay, what is the prognosis like? Treated patients, adrenal crisis and infections do cause excess deaths. If you prevent adrenal crisis, disease can be managed successfully by replacement therapy. Mean age at death is around 65, that is 11 years estimated decrease in the life expectancy. When 11 years decrease, women they lose only 3 years. Always women are powerful, so they lose a less number of years compared to. Even genetically also you are double X and he is single X. So who is powerful? You are powerful or he is powerful? So exogenous steroid use. Exogenous steroid use. Replacement steroids are vital in those taking long-term steroids when acutely unwell. Adrenal insufficiency may develop with deadly hypovolemic shock. Additional steroid is not given. Warn against abruptly stopping steroid. Give steroid card. Emphasize that prescribing doctor, dentist, surgeon must know how to use the steroid. And in the old age, what you see is glucocorticoids in the old age. Adrenocortical insufficiency, often insidious and difficult to spot. That is why it is the disease of death, guys. We have said. Glucocorticoid therapy, especially hazardous in older people who are already relatively immunocompromised and susceptible to osteoporosis, diabetes, hypertension, and other complications. So, before putting a sort of elderly person on glucocorticoids, think about the hazards of steroids. These hazards are much more in elderly because of osteoporosis, diabetes, and hypertension. Physiological glucocorticoid replacement therapy increases the risk of adrenal crisis because of compliance may be poor. There is a greater incidence of intercurrent illness, patient and carer education, the regular reinforcement of principles. Now, you see the Edison's disease, bronze pigmentation of the skin, changes in the distribution of the body hair, hypoglycemia, postal hypotension, weight loss, GI disturbances, abdominal pain, vomiting, weakness, profound fatigue, dehydration, vascular collapse, renal shutdown, decrease in sodium, increase in potassium are markers of adrenal crisis. Signs and symptoms of crisis I have told you: shock, coma, and high temperature. Precipitating factors: infection, trauma, surgery, missed medication, patients with known disease. Remember, bilateral adrenal hemorrhage due to meningococcemia can cause sudden Waterhouse Friderichsen syndrome. Okay, management of adrenal crisis: treat before the biochemical results. Don't wait for the biochemistry if suspecting crisis. Give steroid. Bloods for cortisol and ACTH are taken, and then go ahead with the treatment. You can have high potassium, check ECG, give calcium gluconate if required. Low sodium, salt depletion should resolve with rehydration and steroids. Hydrocortisone stat 100 milligrams, IV fluids 500 milligrams of N saline to support the blood pressure, monitor blood glucose and blood urine and sputum culture, then antibiotics if necessary. Management of adrenal crisis: IV saline, hyponatremia is severe, you treat it. Fluorocortisone, replace glucocorticoids. Correct other metabolic abnormalities like hypoglycemia and hyperkalemia. Identify and treat the underlying cause. Hypoglycemia, IV glucose. Clinical state and electrolyte imbalance, IV fluids. Steroids, you continue. Adrenal disease, add fluorocortisone. Find the underlying cause and treat that. So this is a note from one of the textbooks. This says how a woman with Addison's disease, undiagnosed Addison's disease is described. We read it out. What is that?
Typical day wakes up at 11:30.
Wakes up at 11:30. I told you.
Still feels tired. Then will have some breakfast and usually fall asleep on the couch. The most energy requirement activity.
Couch means not on bed. The sofa itself she sleeps.
The most energy required activity in last 1 month is cooking herself a pasta meal. Then totally exhausted, will sleep more in PM. Then eat some dinner. Goes to bed at 11 PM latest. Not able to concentrate. Used to weigh.
Weight loss.
Weight loss. Used to weigh 45 kg.
Now weighs 43 kilos weight loss. Less than.
About Addison's disease, we might think there are sufficient clues to raise the suspicions of Addison's.
What are the clues in this lady? Listlessness, lack of energy, loss of weight, and elderly lady. These are the clues. Okay.
Even though her electrolytes were not particularly oily and the pigmentation was barely perceptible, but change the context to her last visit clinic. We are a little distracted. The memory of Addison's is fading. Who among us will hear the well-being?
So people are forgetting Addison's disease as it. So memory is fading about Addison's disease. They are not considering what a very easily treatable disease. All you require is hydrocortisone tablet and mineralocorticoid tablet diet. Only thing is you should have a suspicion. Hyponatremia, hyperkalemia, hypotension, hypoactivity, hyperpigmentation. Whenever you get somebody like that, should think of. Summary. What is adrenal insufficiency? We have seen. Primary and secondary. Features we have. Investigations, we know. We have to measure the 0 ACTH, 0 hour, and then 0 and 30 minutes cortisol after giving synactin. Making diagnosis, treatment and follow. Addison in crisis should not be performed. Okay, we will stop here.